accessory muscles obviously having respiratory distress.
Can you tell me why? Well, you said it's obvious, but I'm kind of dumb, so.
Why he's in respiratory distress?
Yes.
Oh gosh, well they got him on that too. Maybe.
Somebody thinks so, huh? Okay.
He's sick. That would be my guess. He's sick.
I like that. Now, I know it's a little bit rough to say it, but we've got all these fancy terms and everything like that. And one of my favorite ER docs that I ever worked with, I'll go ahead and throw his name out there, give him a shameless plug, Dr. Thompson. I would take patients to him, and him and I could have a really good conversation about what's going on with the patient. And I brought one in one day, and I couldn't figure it out. I had no idea, so I asked him, what do you think about this female? It was a female patient I brought him. He said, in so many words, she's sick. And I'm like, okay. He's like, I don't know either. So I like your approach to this. We could use all the pediatric assessment triangles and stuff, but you're just looking at it from an EMT perspective, a new EMT going, that kid's sick. That tells me you're probably going to transport this kid. Okay, that's what I really want you guys to know about. But please continue with why you think he's sick. Because the registry won't let you get by with that. He's sick. I wish they would, but. Anything else?
His mouth breathing.
Mouth breathing? Okay, Luke said accessory muscles. Labored.
I couldn't quite tell, but it looked like it might be a little bit uneven.
Irregular respiratory pattern. What about his appearance?
Sleepy. Yeah, he's
Mouth's open.
Yeah, I was trying to figure out why he's distressed enough to be breathing like that, but not so much that he's awake and.
Okay, so we don't really know about that, do we? I mean, is it normal nap time for him, or has he been up all night, or did they give him something to rest? We don't know those things, but he's obviously not aggravated and crying and things like that. Okay, Luke, you're off the hook. So far, so good, okay? So far, so good. So we're going to take this same kid and Chas. We got some information now. Since you're not there with the stethoscope, he has expiratory wheezes. Expiratory wheezes. What's that tell you? What do you know about expiratory wheezes?
He probably has a chest infection.
Okay, yeah, it's in the chest. It's lower airway. It's below the glottic opening, so it's a lower airway issue. It's bronchial inflammation, most likely, isn't it? Constricted airways on expiration. Do y'all remember what diseases give you wheezes? Asthma, right? It's probably not COPD, bronchitis, and it could be acute bronchitis, but it's not chronic bronchitis. It's not emphysema. This kid hasn't smoked yet, I hope. Possibly, but yeah. It's kind of back to Luke's little scenario here, where he just state the obvious. Hey, the airways are inflamed. Yeah, could be pneumonia. Couldn't be pneumonia. All right, Chas, back to you. Back to you, Chas, because we've got some monitoring devices. We've got some vital signs now. His blood pressure is 96/62. Good or bad?
Bad. That's bad.
Why is it bad?
It was pretty low. And it says
Okay.
right there,
Okay, so somewhere. Oh, don't worry about that. Don't worry about that. What you see there, Chas, on the 160/90 are the alarm phases.
Yeah.
So if the systolic falls below 90 or rises below 160, it's going to go, and just sit there and alarm until somebody acknowledges it, okay? So those are alarms. Anyone tell me what the 73 in brackets or parentheses are? MAP. That's his MAP reading. mean arterial pressure. And that's calculated from the 96/62.
It's above 65, so it'd be.
Okay, so the map's above 65. You guys sound like a bunch of paramedic students. I mean, damn. Come on, right?
His SpO2 is a little low for a baby too.
SpO2 at 94. Chas, let's take this one at a time, okay? All right, Chas, let's go back to you for a minute. Everybody's giving good input, but I want to put Chas on the spot because she's mean. Look at his trending vital signs. He was 80/48, 84/60, now 96/62. Are we getting better? Right here in the little writing.
It's just really small.
Yeah. I mean, that was just 2 minutes ago, so I don't know about all that.
I mean, it's getting
If you're taking it that frequently, you're getting an accurate reading. I hate to tell the person who keeps hitting the button. The blood pressure is fine. I'm not concerned about the blood pressure. You guys are accustomed to the adult blood pressure. In the adult, this would be alarming. In a child, great. Be sure you look in your textbook over normal vital signs just for the age ranges. I can't quote that chart to you, but I'm looking at this going, I'm not worried about that. Chassis pulse is 136. Good, bad, or okay?
I'd say it's okay.
I'm okay with that. I'm okay with that. Respiratory rate, 38. You good with that?
I think with his age, what I'm assuming is his age, it should be just a little higher. But it's okay.
Maybe a tad bit fast, but I'm not. Let's go to the SpO2, the actual concentration of oxygen on the hemoglobin. It's 94. Needs an updraft
That's probably why they have it on oxygen.
to bring it up a little bit. Well, it's 94 on the oxygen.
Yeah, baby's also compensating really well.
That's what I'm saying.
So I was doing pretty right.
That's probably why they have him on the oxygen.
Yeah, he's 94 with the oxygen.
Yeah, that's a little alarming to me.
Yeah, what is it without the oxygen, right?
Yeah.
Heart rate 136. You cool with that?
136. It's
Please-
okay, but it could be.
Please understand something as you look at this, okay? This is on a pediatric advanced life support video. Is there anything here an EMT could not acquire in an assessment? Is there anything an EMT could not acquire in an assessment? Can you get a blood pressure? Can you get a pulse rate? Can you get a respiratory rate? Can you get an O2 saturation? Yes.
I'd say the only thing they're missing is the capnography.
Yeah, it's hard to find capnography in the hospital for some reason. Can I teach you something else right quick? No yet. You okay with learning something else? You won't find it in the textbook. You probably won't find it in the paramedic textbook. But lucky you came to class today. You see this word called pleth? P-L-E-T-H? Pleth? So pleth and SpO2 go together. SpO2 from a pulse ox just gives you a number. Pleth gives you a tracing of the O2 saturation. Do you remember how the O2 sensor worked? You got an infrared and a visible red emitting device, and they bounce light waves off of the blood cell. So Chas, you and Riley are the sensors and the light emitting devices, the LEDs. So here comes a blood cell. You're measuring it. Now the blood cell goes on off to get recirculated. Here comes a new blood cells. So how does the blood cell move in front of you? Periodically, that happens to correspond to the period of the Heart rate, yeah, the ventricle contracting. What's pushing me along? The ventricle. That pleth line almost identically lines up with the heart rate, doesn't it? It's a little bit behind, actually. And that would make sense, wouldn't it? So it's a new blood cell. It's the next blood cell coming in front of the sensor. You understand pleth lines now? It's pretty cool because sometimes, especially in CPR, I can start seeing a pleth line appear way before I can actually feel the pulse. So it's an indicator for me sometimes that I have ROSC, or return of spontaneous circulations. When that pleth line really gets to growing, or it's there without my compressions. Billy, was that you? Jonah?
You're saying good CPR.
Yeah, it could indicate good CPR as well. But when it starts getting faster than my CPR, because it's going in there along with it, it's just another indicator that things are doing well.
Based on the breath that that baby has very shallow breaths.
No, you can't tell how deep they're breathing by that. All that is just a number from 0 to 94. The top of these peaks average out 94. If it maxed out, it'd be 100. So it's if you do an XY Cartesian coordinate system kind of thing, it's 0 to 100 on the y-axis, and it's just reaching that. So, Chas, Luke said 6 from across the room. I mean, sick from across the room. Are you still saying sick now that you know more information?
With the expiratory wheezes, yeah.
Expiratory wheezes, O2 saturation at 94 while on oxygen. I'm gonna stay with that. At least not yet sick, but certainly on the sick side of life. Okay, very good. Stare it. Let you do case number 2. One more time, stare it. Got some cool ass shoes, don't he? Talk to me.
Well,
Sick, not yet sick.
sick.
Why?
Having trouble breathing, and I don't know if that's coughing or sneezing, but he's doing something. I think it's coughing.
We call those modified forms of respiration.
Really?
Yeah, we do. We have a name for that.
He's like belly breathing.
A cough, a sneeze, a gurgle, a sigh,
Okay.
a hiccup, a hiccough are all modified forms of respiration.
Am I wrong to hear? Am I hearing Strider?
You're hearing something.
Yeah.
Did you hear that?
I thought that was birds in the background, but maybe not. If you played it,
Does this look like a meadow?
no. But I did hear that. But I was listening to it, and it sounded like there was birds outside the room.
Frank, Frank, help the poor boy out, okay?
No, I was confused too. That's why I asked.
Yeah.
Play it again.
I didn't know if that was like noises from inside the hospital.
I heard it.
All right, so I'm gonna turn it up this time, okay?
No, but I asked for
Yeah.
Like, look at his belly. Yeah.
That time it's a lot more obvious.
Sounds like somebody's whistling.
So when
There's like a block in
Is
front.
that the seal-like sound?
if it is, it's subtle. I mean, I've heard it a whole lot worse than that.
That would be the upper respiratory.
Have you ever had those infections in your lungs or your airway when you take that? You don't want to breathe real deep because it makes you cough. You know, like you avoid the cough by breathing shallow. I kind of feel like he's in that position. Stare it, do you? When he needs that deeper breath, it's stimulating a cough. So sick or not yet sick?
Sick.
Sick.
The skin on his face looks a little weird too.
Is appearance off?
Yeah. Looks uncomfortable.
He seems to be he seems to be decently calm.
Is he abnormally calm?
I mean, he's not like panicking.
I feel like it depends on how he was raised. If he's been here before.
If he was sheltered or not.
So you bring up a good point. How do you know? How do you get that information? Parent.
He's already tagged, so he's probably been there for a while.
Okay.
I have no reason to be suspicious. He's just, he looks confused. He doesn't look like he's.
He's well behaved, isn't he?
Yeah.
You find him well behaved, Billy?
His mom uses the charger.
Pretty scared.
He knows something's up. So, Stair, anything you want to add to that before I give Nate the secondary assessment? He certainly is modeled.
Could I call that Strider though?
You're hearing wheezing.
Was I thinking of the wrong thing though? Okay.
His breaths are way out. His respiration.
All right, this is Nate. Talk to me, my man.
The respirations are really high. The oxygen seems good. Non-oxygen's at 97. Heart rate seems okay.
Blood pressure okay?
Yeah, I would say so. Wheezing,
Respiratory rate is
super high.
too high. It's 50. And shallow.
Yeah, he's probably breathing shallow.
What should the range?
His age group, I would not want it past 30, I don't think. You guys can look in your textbook and get the actual hard number out, but with his condition of wheezing and diminished breath sounds, he's trying to compensate. He's making up tidal volume by increasing minute volume. Or he's making up a lack of tidal volume by increasing the number of minute to equate to a good minute volume.
Is it gonna tell us diagnosis?
Uh,
Because now I'm curious.
now you want to know what he has? Does it matter? What's wheezing? What's wheezing?
Not how we treat them, but just to satiate curiosity.
Even if the doctor knew what it was, they're going to do the same thing.
Right.
They're going to probably give a bronchodilator. They are probably going to swab him for strep and send him home with corticosteroids and tell mom it's probably viral. See, it's easy. I'm being very jokingly there. Christian. He's an Arkansas baby, Christian. I'm just taking that off the name tag. Okay, don't be offended. Sick or not yet sick?
Well,
Upper airway. He's struggling to breathe when he's really. Oh, my bad.
Yeah, it's okay, Billy. It's okay. I know you're ready to go. I mean, it's just like, get this out.
I was gonna say sick, but usually when kids like that are upset, they tend to breathe through their stomach a lot more than usual.
Okay. I don't have a problem with what you're saying, but
But since he's crying,
do you remember a term I used called scaphoid? Scaphoid abdomen, scaphoid chest. I said you could eat a bowl of cereal out of the chest. Watch his substernal, we call them substernal retractions. So Christian, watch his sternum. You see that when he inhales? That sternum really sinks in, goes deep. Everybody see that? I mean, if you're not looking for it, you may not pick up on it. Those are retractions. So when he inhales and he's creating a negative pressure in his lungs, he's creating more negative pressure than normal, and therefore the atmosphere is pushing on those other areas. This is probably, and I'm suspicious right now, see if you agree with me, Christian, I'm suspicious of an upper airway constriction or obstruction. If it can't go in here, if it's restricted going in here, therefore I get the retractions. Y'all following? Y'all agree? Agree? Yeah, he's irritable. He's irritable. So, Billy. Billy, keep watching because you're going to get the secondary assessment. Is that some accessory muscle use too? Some belly breathing? All right, Billy. Billy. Old Brandon said, I think his upper airway may be constricted because he's got these substernal and intercostal retractions. Did I say that? So what noise, Frank? What noise, you've been wanting to say this all day, what noise comes with an upper airway obstruction? Stridor. So now we got some stridor. Closing down on the upper airway, making it hard for the air to go in when he creates that negative pressure. Therefore, it presses everywhere else. You following along? Okay. So, Billy, heart rate 109. Good, bad?
I want to say good, but good, yeah.
Why?
It's not under 100. It's not.
Okay.
I want to say
It's 109, though. I mean, I'm concerned. I'm concerned about his heart rate.
his respiratory is a little bit lower for his age.
That's between 100 and 140. Or is it 120?
What about his respiratory again?
We got some.
You said something about his respiratory.
It's lower for his age. At least, I don't think he's over
Okay.
3 years old.
This is such a is the word conundrum? Am I using the right word there, conundrum?
Yeah.
Like, this makes zero sense and I need to sort it. The chart in your book isn't worth a damn, but the chart in your book's pretty good because it gives the normal values. But what you want to do as the new EMT, and even paramedic students try to do this, and even some experienced people try to do this, well, it's within the normal range. How many times you look at 109 and go, well, it's above 100? Respiratory, well, I mean, that's probably for his age, that's okay. Not for his condition, though. This kid's sick. We knew that. Who knew that? Christian? You knew something was up, didn't you? So you start looking at the vital signs and going, heart rate of 109? Come on now, this kid's struggling. Respiratory rate of 23 with stridor? What? I don't like that. Blood pressure, it's holding, 94/50. Pulse ox 96 on room air. He's not getting any accessory oxygen, so he's still maintaining oxygenation status. Let me ask you these words. Is he in respiratory distress, respiratory failure, or respiratory arrest? Okay, in your notes right now, I don't care if you write it down or burn it in your brain, those three words we talked about, or those three phrases we talked about in respiratory emergencies for adults, right? And respiratory distress was they're having trouble breathing. Respiratory failure, they can't maintain oxygenation. Respiratory arrest, they're no longer breathing. So you just told me this kid's in respiratory distress? Yes, no?
Yes.
What would cause him to move to the next phase of failure? How would you identify failure?
SpO2 reading.
Okay, SpO2 reading continuing to decline. It's kind of like shock. Do I wait till it gets bad to do something about it? Why would I, right? I'm going to say that if you do the distress or failure arrest analogy, there's got to be some overlap there, doesn't there? Luke, is there overlap in that? So as I go from distress to failure, do some of those things line up and hide behind themselves? Can some of that distress reach all the way down to arrest and have some overlap? I think so. I think you need to think about it in that sliding scale, if you will. He's getting pretty damn tired at 23. All right, major milestone moment. And this is where I take the curriculum and I kick it square in the butt. And they're like, the curriculum is so wrong here. Actually, I don't know if it's the curriculum or just people who say this. But I'm about to put a myth to bed. And if I ever hear you resurrect this myth, I'm going to kick you in the butt. There are people out there who say, there are people in my position, there are people in education, there are people in medical community, physicians and the like, who will say, this kid is compensating, and I'll say, maybe. And then the same person will say, kids can compensate for a really long time, but when they crash, they die. They just fall off the cliff. They compensate forever, and then they just fall off the cliff. And I will say, you're wrong. I'll say you're wrong. I'll say kids can't compensate. Follow my thoughts here. Kids cannot compensate. Therefore, when they fall off the cliff, they fall fast. Does that make sense to you? Adults, healthy adults like you can compensate. Kid cannot. They don't have that resiliency built into them yet. What about the old person? Can they compensate very well? No. To grow old is to grow young. Kids cannot compensate. There are people who say they will. Who's right or who's wrong? Don't wait around to find out. At least in mine, you're erring on the side of caution. At least in my thought, and I totally commit to myself that they can't compensate. They're young. They're resilient. Bull. They are not young and resilient. They're young, but they're not resilient. This kid at 23, to me, sets off an alarm. 109 sets off an alarm. This kid's struggling. He's scared. He's in a hospital. He should be a little more tachycardic than that. He can't get any air into his body. He should be struggling a little harder than that. What's he about to do then? He's about to crash. Somebody's going to turn around and come back in the room and he's going to be in arrest and go, what happened? Well, you know what they say. They compensate for a long time, but when they die quick. I don't want you in the mindset in the field going, he can probably hold this for a while. He can't. He can't. This alarm needs to go off right now. What's the harm in it going off right now? Nothing. There's no harm, is there? Is this kid sick? Christian said this kid's sick. Look at his retractions. I don't need the numbers. Now the numbers are starting to make sense. They fit the norms, possibly, but no. Where are they trending? They're trending in the wrong direction.
So with this kid, you're saying epiglottitis, right?
No, not yet. I'm not. I'm just saying it's upper airway involvement.
Okay,
Yeah.
so would you, if you know it's upper airway and it's going to work? No, because there are measures to take before that. As the EMT, I just need to know, get this kid up, be ready to resuscitate this kid, be ready to support his respirations with the back valve mask. If they fall any further, or he goes listless or lifeless or loses his tone, this kid is tired. Frank, do you have a question?
You just answered it.
Okay. So That's at the EMT level. At the paramedic level, let's start nebulizing. I think a great thing before I get there, a great thing for the EMT would do, humidified oxygen. I know he's at 96. How about a humidified air? Soothe that throat down. Whether it's epiglottitis or croup or some inflammation. If you end up giving this kid oxygen, please humidify it. It needs to be moisture laden. That will help soothe that down, yes.
How you do that?
You just run the oxygen through water.
Could be a little saline.
Yeah, there's a bottle of sterile water that screws onto the bottom of the regulator in the ambulance. Some ambulances don't carry them. I think it's a disgrace to not carry them. But in the hospital, definitely they'll have humidified oxygen. I could nebulize. I don't really need albuterol because that's a bronchodilator, so that's not going to work there. If I got a long transport, I might go ahead and get corticosteroids on board as a paramedic. I might give him a little solumedrol or something to help the restriction. Yes?
Would you say his posture is not helping?
Thank you, 100%. Maybe if we just lift his big old head up off of his kinked trachea, he might not have stridor anymore. I've been to nursing homes. His pulse ox is 68. Take the pill up behind their head and it goes to 90. It's like, have you thought about, does that look comfortable? So thank you for noticing that. This kid needs to set up a little bit.
Say this kid does crash though. Would you consider an OPA?
Sure. And is your concern though about the irritation of that? By putting something in their mouth and irritating an already irritable airway?
Yeah, but I mean just more.
If you have that concern, that's valid.
Well, say it is epiglottitis, right? Say it's the swelling.
I'm with you. Yeah, I'd probably avoid it.
That though, and stop that from happening?
That won't stop it. OPA won't stop it. It might cause it. It won't stop it. It might cause it. You guys are having a great discussion today. You know why we have a great discussion? Because we'll get away from the textbook. You'll find that. I would head tilt, chin lift him to some degree. I'd certainly pat his shoulders. I wouldn't want to kink it because it's already kinked the wrong direction, isn't it? It's hyperflexed. I don't want to hyperextend. So I want to keep it neutral. And if I'm worried about epiglottitis, if there's a history of drooling here, I'm probably going to avoid the OPA. This kid's getting tired. Just to help you keep the airway open, help to keep the tongue off the back of the throat. And the majority of the time I would, but if I'm worried about epiglottitis, I could make it worse by using an OPA.
NPA?
No, because it's nasopharyngeal too. Remember, you can ventilate someone without those adjunct devices. Yeah, so if you can do it without it, do it without it. If you can do it without it, do it without it. Now you take an old guy with a stroke, and because his airway's flaccid back there because he's lost innervation because of the stroke, OPAs and NPAs would work great in that one, wouldn't it?
I'm just worried because like if he crashes, it's obviously because his airway's lost at this point. If I use it,
Hang, okay.
say it is epiglottitis, right? The swelling, he's lost that. So how would I, as just an EMT, say it's me?
It would be a pain in the ass to ventilate him if he's in an laryngospasm. And an OPA will not help you.
There's nothing I can do. What about like an element? Would that work? If we had those?
Nope, lid's closed. Say that. You don't have to say that word, but just no. And no, I want you to say that word. Is what I'm getting at. I want you to say something along the lines of. There's probably not a better word. So what Jonah's doing, he's sitting there, he's running through his list of tools to correct this kid in epiglottitis laryngospasm, and I say none of them work. And he says the F word, and I want you to take that away and go, epiglottitis is a big ass deal, isn't it? I can't jack around with an epiglottitis. Yes.
The treatment for that is fast and lights and sirens.
Yeah.
Oh yeah, you okay with lights and sirens?
Yeah, I am now. Not because Granny bumped her toe, but
I got a kid whose airway's closed up completely. Yeah. Is there an ALS intervention possibility? Trach, crack. I can go down with the laryngoscope and try to manually pull that epiglottis up a little bit, but I'm not going to get near as animated as I am. I'm going to gently try. Is that going to aggravate? Yeah, but it's already closed. It's already laryngospasm. I could take some topical lidocaine in a syringe and get it down in there and just spray some lidocaine on the back of the airway to kind of numb it, and that might release the laryngospasm. Yeah, and that's if I have that. Even if I have lidocaine on the ambulance, they got lidocaine spray that I can spray on those vocal cords. I could administer a paralytic, which will make those muscles release, but that's going to take a little time for onset. But depending on the paralytic I use, sometimes the onset's within 30 or 40 seconds. Could be life-changing. There is some theory that if I tap the vocal cords with the ET tube, kind of knock on the door, that they might relax and open up. Who knows? Who knows? It's a hell of a lot more than you can do. And I don't mean that in a braggadocious way, but I'm just saying it's certainly an ALS call at that point. But he's in the ED right now.
Would you look into the kid's throat?
No.
See if it is.
Mm-mm. Nope. Not even in this kid here would I pry in the mouth and look, unless I'm worried about a foreign body airway obstruction.
Yeah, you can see that.
And as long as his breathing, I don't even try to relieve that. But this kid's not coughing like if he had a toy Easter egg or something in his mouth. Yes, Luke?
Could it be allergy related?
Such as he got exposed to pollen, and it could be. It could be, but we'll probably hear more wheezing with that instead of stridor. But it could be.
With epiglottitis, when it fully closes up, will they act like they're choking for a few seconds and then pass out?
Yeah, they'll act like they have a complete airway obstruction. Please, let me make sure you're clear on something. Epiglottitis is a condition. It's not a closure. Epiglottitis could lead to laryngospasm. I mean, you can have epiglottitis. You probably have had epiglottitis. You probably had a strep throat or some viral infection in your throat where you had, somebody's probably sitting next to you and go, man, I hear you breathing. Yeah, my throat's been sore. That could have been epiglottitis. But in these pediatric kids, or these peds, like they're pediatric adults, it's so irritable that it doesn't take much to stimulate that gag reflex and just totally close it down.
What's your big telltale sign of this?
They haven't swallowed, so they're drooling. Drooling with a fever. Unfortunately, we don't have a fever on this kid, but Christian said substernal retractions. He knew immediately this kid needs to go to the hospital. Now, you're going to take vital signs on the way, but did you really need them? Yes, Starrett?
I would think they would have a temperature on them.
Somebody probably has, but it just doesn't show up on a monitor. Any questions on that? Do you got a kind of a better feel for pediatric respiratory emergencies? Do you have a better feel for the PAT, the across the room PAT? You've learned about positioning. You've learned about stridor, upper airway, wheezes, lower airway. You've learned about management, Jonah, if the kid does crash. What are some advantages and disadvantages to my adjuncts? You've learned about might fall within the normal range, but it certainly isn't good for the condition the kid's in. Yes?
Is this kind of videos like this available to the public? Like,
Boy, you would think they would be on in your textbook resources, wouldn't you?
Like, can you?
Yeah. Sure. YouTube the hell out of them. But this is an American Heart Association. It's real easy for me to get the thumb drive and throw it in there.
But what are you getting at, Sterrett? Continue your.
Just so you could look at different issues and
Yeah,
be able to identify.
YouTube's full of it. YouTube's full of it. And I often say I shouldn't have to lecture anymore. I should just coach and guide. If I could drop appropriate links into each module, and that's what Regan does, you know, that's his business, helping us coach and guide you. Nobody's going to lecture on chest trauma better than a thoracic surgeon, right? But you kind of need me to get the verbiage out and kind of understand it. So it's good ancillary, it's good capstone to the module, if you will. And look what it's done. Look what it's done to the lecture. How many questions have you guys asked now? And I'm glad for that. Okay, so let's get into this next module, and I'll just leave this up and I'll just do the talking. So the next module you see on your slide as shock video case discussions, and we'll play with those as well. So if the kid's not respiratory compromised, he could be in what other type of compromise? Cardiovascular. Cardiovascular. I mean, what two things will kill you? You're not breathing, or you don't have a heart rate, or you've lost your blood. Do kids have any capacity for resilience and blood loss? I just told you they really don't in respiratory. They don't in blood loss either. They do not in blood loss either. So that, what we know as an adult, we have the compensation, decompensation, irreversible. They just kind of skip from one end to the other.
Are there pediatric trinkets?
Like for your stop the bleed kind of thing? Not really. Not really. You see those for, pop up a vein for vascular access, but for a bleeding control, there's not. And usually you don't need it because you can wrap pretty tight with a hand. I'm not saying you can't use a tourniquet on a kid, but they don't commercially develop them for them. Not that I know of. Because they're not, I mean, they can get that kind of trauma, but the market and all that. But the technique would be the same, Jonah. Yeah.
Would a regular size tourniquet work?
It's usually got that hard band in it, and it can't bend that much of a radius. So they can lose blood, or they can lose fluid, or they can. So what types of shock are there? Once again, let's go through the list. There's hypovolemic shock, and by definition, you have lost volume. Whether that's blood or you've just been dehydrated with diarrhea for 5 days. Do kids get into diarrhea for 5 days and can't eat kind of environments? Sure. They usually don't have blood loss unless it's a trauma. What other types of shock is there? Anaphylactic, but that's on the respiratory side. Neurogenic, septic. Do kids get septic?
Yes.
Sure. Distributive. Good job, Billy. Billy knows his shock, don't he? What about cardiogenic? No, I mean, you just didn't exhaust the list. I'm not saying you're wrong at all. Billy, you're not wrong at all. You just didn't exhaust the list. So I want to focus on, there's two things I want to focus on kids that are most likely. Cardiogenic, which is heart related, and hypovolemic, which is loss of volume.
What's it called when it's a container problem?
Hypovolemia, but we add the word relative in front of it. That's distributive shock. Relative hypovolemia, the container opened up more than it should. You didn't lose any fluid, you just got a container fluid mismatch. It's all starting to work now, isn't it? All these little pieces you've heard for 16 weeks are starting to come together, or 14 weeks, I should say. What is the number one cause, ding ding, the number one cause for cardiac issues in a pediatric?
Respiratory, right?
Thank you, Gus. The number one cause for cardiac issues in a pediatric are respiratory issues. You started seeing that in our last case. The kid was he had the stridor, he wasn't doing well, heart rate was 109, you come back later, it's 88. Come back later, it's 68.
How did we resuscitate those low heart rates before? We started with the BVM, didn't we? And we do that again today. We bring the BVM involved. Get the respiratory rate fixed, the heart rate should correct itself. Are there kids born with cardiac issues? Absolutely, more than ever. That's an ethic. We can get into an ethics debate if you want to get into one over that, and I don't really want to spend the time to do that. But the gist is, because of modern medicine, kids with genetic, or people, I should say, with genetic abnormalities that causes a genetic malfunction in the shape and the growth of the heart live to reproductive age now. And that's awesome. That's applaudable. I mean, your kid didn't die. The kid, through modern medicine, got to live and be an adult and die of an old age. But the genetic issue is still present. So that's the morality and the ethics behind it. But I just need you to think about it. We have more people in the population today with genetic abnormalities in their heart. And so we see kids dying of sudden onset cardiac arrest, sudden cardiac death. And they're just prone to go into a VFib or a VTAC without provocation. So we do have those issues as well. So we get into the cardiogenic shock side of things. So I'm going to play some videos and we'll expand this lecture as we go through it. You cool with that? Yep. All right, let's see, Miss Amber. Let's take a shocky kid. Thoughts? You agree? Yeah. Okay, mouth breathing. Let me ask you this question though. You're doing the pat. You're across the room. You haven't laid hands on them. Sick, not yet sick? Sick. Sick. So if you're in a house with this, if you walked into a house and seen this kid or an apartment or home dwelling, is transport on your mind? Yeah. Okay, cool. What else do you notice? He said mouth breathing. You agreed.
She has a feeding tube.
She has a feeding tube. Gives you an indication that this child has a more chronic condition, a longer lasting condition, has to be fed through the PEG tube. Has a feeding tube. Everybody see the feeding tube? So that's where they'll connect the nutrition. Yeah, color's off, isn't it? Color's off. Amber, anything else you want to say? What's worker breathing? Is there an issue with the breathing?
Yeah.
It didn't look good to you? Appearance?
Pale.
Muscle tone?
Weak.
That's 3 out of 3. That's why you said sick, huh? Something congenital here, huh? Quite high possibility that this child was born with an issue. Or at least developed one, still in diapers. No teeth. Long-term care because they put tape on the face to protect it from the nasal cannula. So you walk in here, this kid would be a home health kid. If you found this at home, it'd certainly be home health. Chronic, special needs, chronic needs. Lots of sample history to be gathered by the caregiver. Just exactly what's wrong here. What are we dealing with? I walked in on a kid one night and the mom said, "We gotta go to Children's." And I said, "No, you don't tell me where to go, Mom." She's like, "We're going to Children's." I said, "I have to take you to TMC. I just can't run off to Children's right now. It's not the nearest appropriate facility." She said, "I disagree with you. I think it is the most appropriate facility, and that's why we're going there." You don't argue with a mom. I was a little more politically correct than what I just portrayed, but I called my doctor. I called my medical control. And he said, "Well, what's wrong with the baby?" And I said, "What's wrong with the baby?" She said, "I can't pronounce it. Can you?" And she, by this time, had paperwork, and No, so I spelled it to the ER doc. He's like, I don't know what the hell that is. And I said, well, she wants to go to Children's. He said, have a safe trip. So I'm going to Children's from Denison with a kid that I don't know what condition they have. But the mom had special instructions that if this comes up, this is where we've got to go. And everything was cool. Everything worked out. The kid wasn't like dying in front of me, but they were having an issue with it. And yeah, we're transporting the children. I'm like, okay. I made a call one time where I walk into the house and they said, here, you need to talk on the phone. And I'm like, who am I talking to? And they're like, I don't know for sure. I think it's a nurse at this facility. And I got on the phone and I'm like, this is Brandon with the ambulance. And they're like, are you at such and such address? I'm like, yeah. Like, do you see the child? And I'm like, yeah, it's in mom's arms. Is it awake or is it sleeping or is it dead? And I'm like, it appears to be sleeping. Well, we record a pulse rate of 110. Does that make sense to you? And I felt a brachial pulse. And I said, yeah, it's about 110. And they're like, okay, well, the child was defibrillated about 35 minutes ago because it has an implanted internal defibrillator. And when it saw that heart rhythm, it defibrillated and it called us. This kid had an IP address. It was connected to the internet. And it called 911, called the family, and we're all having a conversation. I'm like, boy, I woke up to this in the middle of the night. I didn't know this shit worked like this. And they're like, so is it, yeah, can you wake the child? Could wake the child, and it was irritable. And they're like, okay, system worked. They have an appointment next week anyway, so we'll log this and continue to monitor. And I'm like, can I leave? And they're like, yeah, there's no need to go anywhere. There's no need to go anywhere. The child had a conduction defect in the heart. So it was a genetic abnormality. So Amber wants to go to the hospital with this. Is anybody just going to say, the Super Bowl's on, can we just go back to the station?
No.
The guy was cooking burgers. I mean, come on.
The Cowboys are on.
Yeah. Amber, do you need a partner?
Sure.
Pick one. Luke, secondary assessment. They call it primary, but I call it secondary. Enhanced. Can we say enhanced assessment? So Luke, the idea of this second piece of video is to give you some numbers, give you some monitoring devices. I don't think you needed them. You were going to the hospital anyway. But now that you have them, does it support Amber's decision?
Yeah.
Then walk me through it. Let me get the numbers up here. Support her decision based on the new box in the video.
Numbers look okay.
Line by line, okay? Line by line. Heart rate. 171 heart rate.
For what he is, being infant, yeah, that's.
Yeah, I think it's okay. I think it may be a little fast, but I'm not.
Considering he's sleeping.
I'm not thinking that it's so fast he doesn't have cardiac output. It's not a rate I want to slow down, and it's really not a rate I want to speed up.
It seems like watching him breathe looks inconsistent. It's not.
Inconsistent with the 30.
Yeah, because watching his chest, it looks like sometimes he's taking shallow breaths, sometimes
Okay.
really
Okay.
deep breaths. It's not really what you want.
All right. All right. Sure. Treat the patient, not the monitor. I love it. Sterrett, you want to ask him something?
No, I was just, what's normal
Less than 2 seconds.
Less than 2?
Good question. Awesome question. Normal in these, less than 2 seconds. Ding, ding. So good question,
Is that
Sterrett.
for just PDs or everyone?
It's unreliable in adults.
What's
It's reliable in pediatrics.
His eyes look kind of,
Hadn't been open in a while, have they?
they kind of bluish. Is that, what can that usually?
Jordan, we have a name for that.
Yeah.
Okay, sure. Cyanosis. Good catch. It's subtle. It's not like the mannequins that we have that goes, LED blue. I'm like, the dead could figure out that kid was cyanotic. And some of these mannequins, we pay a whole lot of money because it's got an LED under the skin and it gets real blue. And it's like, it's as blue as that thermostat back there. And you're like, oh, that's obvious. Who couldn't pick that up?
So that would just,
But you pick that up, and that kid has cyanosis, periorbital cyanosis.
that's just poor confusion.
Yeah.
I think septic.
What, I wonder what his fingernails look like.
Well, they told you 9+ seconds for a cap refill. What are you looking for in the fingernails? Please tell me.
Similar to the eyes.
Okay, sure. Discoloration of the nail beds. Love it, Luke. Love it. You guys are really, really doing well. And that eases my mind a little bit. And I better stop.
Would this baby be cool to the touch, you think? Or a chance?
What do you think?
I would think he would have
Okay, now
extremities.
can I use somebody else in here and we kind of get in a three-way debate? So Jonas said sepsis. I don't disagree that it could be sepsis. And like a blood infection or something. I don't disagree with that.
We're just going based off of type 2. Well, not just based off, but that's...
It's invasive. He's got issues.
Yeah, he's got a chronic stuff, but also his blood pressure is low.
Blood pressure is low. Okay. And you've been in the hospital before, and we know that sepsis alerts are really common. Stare it. Four-way debate. No, go ahead.
With the gap in the SpO2 and the heart rate, is that something or is that just a glitch in the system?
Okay.
Is he in the...
Oh, yeah, that's just the tracing going across.
Okay.
There's really a stylus moving across the screen.
Okay.
Refresh rate, if you will.
Say what you said.
Hypovolemic shock.
Sure. Yes.
That's immediate.
Could it be secondary to sepsis? Sure.
How about just shock?
Could it be a displaced peg tube and not getting the nutrition correct? Sure. So back to somebody's question, is he going to be cool to the touch or warm to the touch? Now in sepsis, we call it an infection. What do we normally think about infections? That we have a fever? But in sepsis, you can be cold too. So he may be febrile or lower than normal.
Did you say the baby be cold just because of the cap refill?
No.
Like be hot before sepsis?
Yes. When you said just in there, I had to go no. So his question once again was, could the cap refill be just because he's cold?
No, it's not. I meant the baby would be cold because the cap refill is nice.
You can have poor cap refill because you're cold, or you can have poor cap refill because you are hypovolemic or in some form of shock. That's why it's so unreliable in adults. But in kids, poor cap refill, I'm going to go with shock. But you're correct. If he's cold, he'd have poor cap refill too.
It's hard to say without any patient history.
Sure. It sure helps to get more clues, doesn't it?
Yeah.
So if you didn't come across this child in the hospital and it's more in a like just a house,
It's more common than ever too, Sterrett, by the way.
what could you do as an EMT?
Back to Luke, I'd like to know what it is. I'd like to know, is this child on hospice? And we don't want to say that because we don't want kids to be on hospice. We want 109-year-old cancer patients to be on hospice. And they got to be 109 before I can accept it, right? Teasing a little bit there. I certainly don't want a 4-month-old on hospice. Can they be? Sure. If he's on hospice, we may not even transport him. If he's on home health, If he's on hospice, whichever the case, there's usually a phone number to call. So as the EMT, I'm going to call that number. If it's not a hospice patient, I'm going to be calling that number while I'm getting this patient ready to move and transport. Does that answer your question enough? Yeah. If they're on home health, there's a home health agency taking care of this case. And it's great to get in contact with them if possible. So you kind of know what's going on. And they may have further instructions for you.
Would you take the nurse or the mom with you? Let's say the home health is there.
They're not going to go with you. They won't ride with you.
Okay.
They won't ride with you. And you can ask. You can say, hey, I'm unfamiliar with this ventilator. I'm unfamiliar with this device that you have attached to this child. You're going to have to go with me. They'll go then. But just a feeding kind of thing, they won't go with you. But I would like for them to sometimes. All right. Luke, what's the most alarming thing in the box that's in the video? What's the most alarming thing to you in this box?
Probably that blood pressure.
This?
I think, yeah.
You think?
Yeah, gosh, the numbers are kind of messing me up.
Yeah, the numbers mess the hell out of you. They do all of us. Artificial intelligence would go, it is within normal range. It must be fine. Within normal range is called compensatory shock. Remember? Blood pressure is okay here.
Yeah, okay.
I mean, you can verify it in your textbook if you want to, but it may be a tad low, but
Well, I guess my second thing then would be his heart rate, considering he's sleeping. Seems pretty high for sleeping.
but it's going to fit in that range. I showed you a slide where it fit. What's the most alarming thing in that box? You haven't hit it yet.
In the box.
In this whole box that's in this video here.
For the patient respiratory.
No, now you're guessing. Come on, Luke. Anything greater than 2 is significant.
Oh, the freaking capillary.
The cap refill is the most significant thing because all of them, all the others, I could probably wedge into the normal box. But this kid's nothing but normal. This kid's not normal at all.
Does that really count as in the box, though? It's not on the monitor.
Trick question.
Monitor's not going to tell you that. Hit me with a curveball.
Did I? Nate. Use your PAT, your pediatric assessment triangle, and give me a sick, not yet sick, and why.
Say sick.
Okay?
She looks like she's kind of out of it, not really with it. Her eyes are kind of slow.
So appearance is poor, okay?
Can't really tell her breathing. She looks like she's breathing okay, not really struggling to breathe.
Okay.
Cheeks are red.
Anything else about appearance?
Probably going through could be a cancer patient.
Okay, doesn't have the hair loss, right? The hair loss. Or could be suffering from a genetic condition, alopecia. But we're going to assume the worst here because that's what we do. We're kind of programmed negatively, aren't we?
I was gonna say she's been there before.
Been there before?
She's used to it.
Doesn't seem to
What
be
about
alarming.
muscle tone?
Very skinny.
Skinny, limp. Wake when opens eyes really doesn't know quite what the surroundings are or why, and then maybe realizes and goes back to sleep like sick, not yet sick. Sick. You said that. So do you have a partner? Sterrett's back. You're a popular guy, Sterrett. So Sterrett, that's your That's your initial assessment. Let's look at your primary, okay?
Heart rate's high, blood pressure's low.
Heart rate's high, blood pressure's low. Okay, okay. Because it's a little bit older child. SpO2 is getting a little low, isn't it? I mean, we're about to hit that 94.
Yeah, she had nasal cannula, so yeah, it's low with that.
Watch this cap refill in the feet. Look at this cap refill.
4 seconds.
At least. You could argue I can still see where they pressed.
Yeah, that's just your brain coming.
It could be. It could be. Let's check again. 1, 2, 3, 4. It's better than 2.
Is that where you normally will check it, or can you check it early anywhere?
Well, if you'll look, they checked it in the toenails, in the toe and the toenails.
Okay.
But it's still capillary.
Yeah,
It's still capillary. And these toenails indicate to me a chronic issue. There's a lot of thickening to them.
Yeah.
They probably can't see through the nail bed very well. So, yeah, you can press on the sole of the foot. So, stare at Nate. Did he change your mind, or is he still sick?
Very much still sick.
Huckabee?
Oh, right.
Give me the 30-foot PAT assessment on this child. Respiratory is a problem.
She's pink. Pink cheeks and do the side.
Well, the cheeks are pink.
Oh, is she a pink puffer?
Close. Muscle tone, okay?
That was not good.
Kid look tired?
Yeah.
Do you have a partner?
Yeah, I think so.
Billy. Billy.
I got 8.
Billy?
I can still see it.
Billy, looking at the box, do you find any problems?
Yeah.
Which one? One or ones?
Well, her blood pressure, her NAP, really, and then her respiratory, it's high up there.
76. That's pretty fast. I think that blows the normal box out.
Yeah. But also, like, the blood pressure, obviously,
Okay, the blood pressure is getting significant, but what's the most significant? Even though it's not listed there, what was the most significant to you in your assessment or y'all's assessment? Her cheeks were pink. That doesn't mean she was pink. Cap refill in the feet.
I didn't see it, my bad.
Huh?
I didn't.
Oh, no, you got to see this. You've got to see this. Can I ask you one more question? When we look at this cap refill down here, I want you to see the cap refill, then I want to ask you a question. So we'll replay this right quick. Isn't that grunting? So you see that delayed cap refill? How accurate, my question is, how accurate do you think that pulse oximeter is distal to that? Not as accurate. So I don't know if I can base much on that 96, do you? It may be inaccurately low or inaccurately high.
Her muscle tone's also
Yeah. Yeah, that's just a,
She didn't reflex to them
Yeah.
touching her feet.
yep, no loss of reflexes, good catch.
Do you consider that a rest at that point?
Nope, still breathing. But the question becomes,
Like a mix of
distress or failure? I'm gonna go with failure. I'm really gonna go with failure. There is some overlap.
Oh, well, yeah, that's what I meant, not failure.
Yeah, no. Yeah, I'm gonna go with failure.
Would you go with hypervolemic? Like a building type of shock?
Doesn't really matter.
I'm gonna go with sepsis on this kid. I think this kid has a temp because of the way those cheeks look.
And with low blood pressure.
And because we're septic aware now. Right? We're septic aware.
I had a question on that kid. So we're not reading heart rhythms on him, but did they look normal?
Yeah, the heart rhythms looked okay. These were all just some form of shock. You want to look at some weird heart rhythms? Here we go, Luke. What are you thinking, Luke? Sick? Not yet sick?
What's on his shoulder?
Over here, betadine.
Betadine?
They probably swabbed it to access something.
It's got like,
Sick or not yet sick?
it's very sick.
Very sick. I didn't know we had a very sick.
What's going on with his neck? They,
Could have done something there. They could have jugular accessed. They bandaged something.
I want to see him.
Okay. You got a partner?
I don't hear you talk much.
Riley.
No.
This guy.
Oh. I thought he was looking at you, Riley. Carson? Who? Shit. Carson's gonna have a seizure. Nothing is good about this. He got to twisting up over here. I don't know if you can see him or not. What's the problem here, Carson? Everything. Cap refill 6, blood pressure map 43, pulse 44, respiratory rate 6, 80 on SpO2. Are we close to failure? No, we're in failure.
We're close to
Are we
arrest.
close to arrest?
Yeah.
Yes.
Are we not in cardiac arrest?
Not yet.
Oh, wait, no, that's even another 30 seconds.
Not an arrest, but
Why was the body breathing for him?
they're letting him die.
Oh.
They've already tried it.
Oh.
It's gonna
Oh.
cause more prolonged harm than good.
I really want to know what's underneath that on his neck.
They probably pulled a trach.
Trach. Yeah.
Got all solemn here, didn't it not?
I wonder what happened. Trauma?
Looks long term to me. Cancer probably.
Well, I know your kid's fun.
Yeah, for real.
What is that?
Gus?
Sternal, heartbeat.
Gus? Sick?
Yeah.
Which part of that failed?
All of it.
Got a partner?
Frank. Knew it. I wasn't paying attention.
Frank, do you agree so far that this is sick?
He was sick.
Yeah, he's sick.
He's got a heart,
bit sick.
had a heart surgery.
Oh, beat that.
Wow. I've never seen a hole like that.
That is VTAC.
I think they're letting him
That is VTAC.
pressure's
Strong central pulses, cap refill 2 seconds. That's fine. SpO2 is good. Blood pressure is good. Pulses.
Well, he's not breathing fast. Is he?
Pulse is higher.
So this is a post-surgical patient. He came out of surgery. He's in recovery. They've got the drains in. He's had probably a procedure on his heart. They may be allowing this VTAC to run right now before they convert it. I don't know.
So what would you say his age is right now? Because
I'm going to guess 9. Oh, well, wait a minute. No, he's probably developed like a 9-year-old, but he's got some facial hair, doesn't he? But he's really kind of developed. He is pubescent. I think there may be some axillary hair.
I'm having a hard time with the respiratory rate. I don't know how normal that is.
18?
Yeah, I don't know how, like for his age, I'm not sure.
Yeah. He didn't develop right. Yeah, didn't develop. And that's typical of somebody with a defect. He was probably born with a heart defect and had to go back in and fix it.
So, could you talk through what that was running up into his chest?
Drains, surgical drains,
Drain?
to drain the excess fluid that's going to accumulate around that wound.
Dang.
Otherwise, it will just build up in them.
That was like run up in his high chest.
Yeah, he was split all the way and laid back.
Really?
Yeah.
They did surgery on his heart. So that's not his heart.
I love this little kid. Do you have a problem with him?
Playing game.
Is he coughing?
He doesn't like that in his mouth, does he? It's kind of a little tender.
It looks like he's coughing.
We don't have audio.
No.
You can't tell like what his breathing sounds like or anything.
Sick? Not yet sick.
I don't think he's sick.
You don't think he's sick?
Nope.
Can't really tell.
Probably has a cold.
Oh, God dang.
Sick or not sick?
Wait a minute.
He said, chest.
Is his heart rate high?
Sometimes I don't know if you're serious or not, Frank.
That kid just ran a marathon.
Well, the pleth does not match the respiration rate. I'll take that for sure.
Well, it won't. The pleth will match the heart rate. Pleth match, yeah. Capnography will match respiratory rate.
Glucose. It's the first glucose.
Cap refill less than 2, glucose 110. It's all right. I'm not worried about it.
What would be high for a kid like that?
Glucose wise?
He's all the same.
Depends on when he ate last. 700 would be. 400 would be. What in the box is alarming? Heart rate. I mean, it even says right there, extreme tachy. Why do you think he's tachycardic?
Scared.
Could be.
What's a normal blood sugar?
There's going to be the same as an adult.
He's scared.
I'm not worried about his blood sugar. I don't think that's an issue.
I think he's a person with doctors. That's why.
80 to 120. Could he be, I'm just throwing this out there, could he be hypovolemic due to lack of feeding? Feeding. If his throat's bothering him to the point where he won't consume fluids.
I don't think so.
You don't think so?
Because his blood sugar's good.
You have glycogen stores.
I just don't see evidence.
You have fat stores.
There's not that much evidence.
Progressively.
He's got strep throat.
I need more details.
I do think something's wrong with this kid's throat. I think he has an infection.
I should just be an MD at this point.
Well, let's go back up.
He don't like that cuff squeezing his arm, does he? So his appearance and his tones there, I think this kid is dehydrated. Look at the side of his skull here. Almost sunken. Let me look at his eyes again. You can tell a lot by the eyes. Yeah, there may be some sunkenness to the eyes. They look dry, don't they? Don't his eyes look dry to you? I think the kid's dehydrated, and that's the cause of his high heart rate. If I'm treating that as a paramedic, if I look at that tachycardia and go, I wonder if I should do something about this. EMT, you're going to call me or take him to the hospital, and that's fine. But I think if I have to treat this myself, I'm going to find the cause of the tachycardia. And if I get a sample history where he hasn't fed in several days, then I'm going to give him some IV fluids.
How do you tell the difference between hypovolemic and septic shock? Obviously, like septic, you'll be sick for a while, but
You may not in the pre-hospital environment. Blood work, lactate levels, capnography, abnormally low, history, febrile or under, not afebrile, but
Can you do an ABG on the spot?
some can.
Would that tell you?
Good, especially on lactate levels. Dr. Lewis runs a lactate reading in his agency at Cook, and it's the same lactate levels a bodybuilder would use, because bodybuilders monitor their lactate levels. So it's an off-label use for really cheap, and he gets away with it by not making diagnosis based on it. What he uses it for is an awareness alert, and it helps go down that septic road. It puts you on the septic road. Yeah, I want you to start working on them for your review. I don't want you to do them just to fill it out.